Good afternoon, everyone. Thank you so much for joining us today for Wise Up on Wisdom Teeth. My name is Cameron Bullitt, and I'm a member of Students for Opioid Safety and Dentistry. We're a group of master's students in the Health and the Public Interest program at Georgetown University. SOS Dentistry was formed as an advocacy effort in response to the worsening United States opioid epidemic. Just on Wednesday, a report from the CDC revealed that the United States has passed 100,000 overdose deaths in just a 12-month period. It's clear we need to continue to fight against this epidemic that has significantly impacted many of us. Individuals under the age of 25 are most vulnerable to developing opioid use disorder. A study published in the Journal of the American Medical Association reported that 5.8% of opioid exposed people between 16 to 25 were diagnosed with opioid use disorder. Dentists are the largest prescribers of opioids for young adults. This prescription normally occurs after third molar extractions. SOS Dentistry has written to the American Dental Association asking them to establish specific clinical guidelines that explicitly state that NSAIDs, not opioids, be prescribed as a first-line treatment to adolescents and adults aged 24 and younger after third molar extraction and other dental procedures. 10 days later, we received a response from the president of the ADA, Dr. Cesar Sabates. He did not acknowledge our demands, but did inform us the ADA has received funding from the FDA and is currently working with the University of Pittsburgh in order to establish specific clinical guidelines. We plan this webinar in order to inform parents and consumers of the dangers of first exposure to opioids in young people after wisdom teeth removal. We have 3 great speakers today that will share their expertise and experiences,
New studies
followed by a
Prolific.
Q&A session. As a reminder, at the bottom of your Zoom page, you should see a Q&A function. Please type your question in this box and we will address it during that portion. Thank you very much. I will now pass it over to Andy Dayton, who will introduce our speakers.
Thanks, Cam, and thanks everyone for your attendance today. I'd like to introduce today's speakers. First, please welcome Dr. Harold Tu. Dr. Tu is an Associate Professor Emeritus of the University of Minnesota School of Dentistry. He retired as the previous Division Director of Oral and Maxillofacial Surgery at the University of Minnesota. A graduate of the University of Oregon Dental School, he received his medical degree from the University of Nebraska and completed his internship in general surgery and residency in oral and maxillofacial surgery. He was appointed as a member of the Federal Pain Management Task Force and is currently recognized as a national advocate on addressing the opioid epidemic and its relationship to dentistry and oral surgery. Next, we'll hear from Dr. Rake, who will share her perspective with us. Dr. Rake is currently practicing at the Dakota Valley Oral and Maxillofacial Surgery. She also serves as an adjunct associate professor in the Division of Oral and Maxillofacial Surgery at the University of Minnesota School of Dentistry. Dr. Rake has gained national attention for her innovative approach to safe and responsible opioid prescribing. Currently, she serves as a member of the Clinical Governance Board with the U.S. Oral Surgery Management and an appointed member of the President of Minnesota Board of Dentistry. Last, Dr. Kat Marriott will round out our discussion. Dr. Kat Marriott is the Executive Director of Healthcare Professionals for Responsible Opioid Prescribing, or PROP. As a scientific project manager, she's been running scientific-based organizations in public health for over 15 years. She's a concerned mother of 2 young adults and has personally witnessed the destruction of prescription opioids. Dr. Marriott lost her sister to an overdose in 2016 after a long battle of addiction to opioids as a result of long-term prescription for an autoimmune disease. After our speakers, we will have a question and answer session with all 3 guest speakers. Kathleen Smansky will moderate the discussion and close out our discussion at the end of the day. Thank you in advance to our guest speakers. It's wonderful to have you here today. And with that said, I'll turn it over to Dr. Tu.
Well, thank you, everybody. Greetings from Omaha, Nebraska. Can you hear me? Can you hear me?
Yeah. Can you turn your video on, Dr. Tu?
Okay, sorry. Thanks, everybody. How's that? Can you let me know if you can hear me?
Perfect.
Perfect. Well, greetings, everybody from Omaha, Nebraska. Thank you for that kind introduction. So first, I want to applaud the Georgetown graduate students for their initiative, as well as their advocacy. I think it's going to make a difference. And I also want to thank for all the participants who signed up for their webinar for their interest. And I appreciate the opportunity to participate in this panel discussion. So next. Go ahead and advance. So I really have nothing to disclose. I'm not, except for the fact that currently I'm a speaker for the National Safety Council. So I'm going to do a little bit different in my lecture today. So I'm going to give you the 4 takeaways for my lecture. And if you gain that from my lecture, then I think I've done my job this morning, which is that this is a study that was done on how dentists pain management to their patients for a number of procedures and how patients responded to that pain management protocol. So the conclusion of the study was that dentists are overcompensating for the level of pain experienced by their patients. Pain from dental procedures are overrated by both dentists and patients, and NSAIDs are sufficient analgesics, and pain should no longer be the image of dentistry. Next. So my epiphany actually started in 2015. I was invited to attend a rally in Washington, an organization called Fed Up, which is an organization committed to stopping the opioid epidemic and addiction, as well as remembering those people who have been lost to the opioid epidemic. And during my time there, I said to my wife as I was walking around that these pictures were the same age as my patients. And then on the way home on the plane, I wrote to myself, why and when did I start prescribing Vicodin? So that was beginning my own journey of self-discovery. Next. So I think Dr. Tom Frieden, who was the CDC director, the 16th CDC director, said it best. We know of no other medication routinely used for non-fatal condition that kills patients so frequently. As you can see, the beautiful flower on the right-hand side is the opium flower, and on the left is the extract from the opium, which is composed of about 12% morphine. And heroin is a semi-synthetic derived from morphine as well as hydrocodone. So in a sense, we can say the following, that when we're giving a pain pill, basically we're giving a heroin pill. Next. So it's already been stated that that we're at 100,000 overdose deaths in the United States. In fact, I have updated these slides, but they weren't included today, unfortunately. So we're averaging 273 deaths per day, greater than cars, guns, and falling. Next. So what we've seen is that the pandemic has certainly exacerbated the number of overdose deaths due to social isolation, mental illness, and access to substance treatment has really exacerbated the numbers. And we're basically seeing a 30% increase from the previous year. Next. When we're looking at overdose death, we're really seeing 3 different waves. So starting in 1999, we saw the first wave, and that was primarily due to prescriptions. The second wave that started right around 2005, we've really seen a rise from heroin overdose. And the most recent, in the last almost decade now, we've seen a dramatic rise in the use of synthetic opiates, particularly fentanyl, has really increased the scourge of overdose deaths. Next. So we're kind of looking at the demographics here, that the first phase, what we've seen of overdose death, has been male, white, between the ages of 45 and 54, and most of these have died at home. And not what we've seen next is what we've seen, the changes in 2020. The profile has changed in that it's now male, young people of color, and actually overdose deaths in blacks have caught up with overdose deaths in whites and an urban demographic. Next. So to put it in context, basically we're seeing a 9/11 every 11 deaths. Every 11 days. And if you kind of want to think about it, is at the rate of 273 deaths per day, it's almost like a 737 crashing every day. Next. I put up this slide because when I first gave this lecture back in 2016, I said to my colleagues that if we don't bend the curve, we're going to see at that time, an almost unthinkable 300,000 deaths in the next 5 years. And so what we're saying now is that the unthinkable has become a reality. We're over 100,000 deaths per year, so we're going to be getting in the next 5 years, without bending the curve, up to 500,000 people dying from overdose deaths. Next. So what and why and when did this happen? Next. So we're really looking at the 4 hydra monsters. So involving criminal behavior, patient expectations, the treatment industry, which is the pharmaceutical industry, and doctor prescribing. We're going to focus really today on dental prescribing, somewhat on patient prescribing, patient expectations, and the pharmaceutical companies. Next. Next. So this remains true to this day, that the United States contains 5% of the world's population consume 80% of the world's opiates, according to a 2009 survey on drug use and health. In fact, if you took Canada, including the United States, we basically are well over 95% consumption of the world's opiates. Next. So what's astounding is that opiate prescriptions have essentially quadrupled starting from 1999 to 2014. So we prescribe enough opiate prescriptions for every 1/3 of Americans in 2015. That really hasn't changed a whole heck of a lot. So in 2012, I think the United States wrote about 255 prescriptions, and we're right around 145 prescriptions to date. So keeping in mind that 4 out of 5 heroin users start with an opiate prescription, and over 50% of opiate prescriptions that are used, if you will, or misused, are from friends and family. Next. This should be a concern to all of us citizens, if you will, that Ann Cass, who is an economist from Princeton, in her study determined that the United States is the only developed country in the world that has seen a decline in life expectancy starting in 2017. And this decline continues in 2020-21. Next. I contend that the opiate epidemic started in 1996, if you will, that time period. Next. So really what the prescribing trends changed dramatically was that prior to the 1990s, time period in which I trained, opiates was not widely used, except for cancer pain and trauma and things of that nature. And then starting in 1996, what we started seeing was a significant misleading advertising campaign by pharmaceutical companies. And then in 2001, standards from the Joint Commission in establishing pain standards. This confluence created the perfect storm for the dramatic increase in pain, use of narcotics in pain management. Next. So what really has changed in America has led to this crisis is the power and influence of the pharmaceutical industry. Next. So what their educational message was the following, that patients were needlessly allowing patients to suffer because of our concern as doctors about the use of opiates. The mantra was that opiate addiction was rare in pain patients, and opiates can be easy discontinued when used for acute pain and for chronic pain. And opiates were safe and effective for the use of chronic pain. Next. So really this graph shows that relationship. What you see is in the green, opiate sales parallel to opiate deaths, and the blue represents addiction treatment. So we're really seeing that these are parallel trend when compared to opiate sales. Next. So what is the role of dentists and physicians? I'm going to focus today, obviously, on dentistry. Next. So this is Dr. Andrew Kolodny, who happens to be my son-in-law, who testified, and he was a foremost expert, national, international expert on addiction, and as well as the opioid epidemic. And he was one of the first physicians to alert the public to the use, the marketing abuse, if you will, by pharmaceutical companies. And he testified in Congress and he said the following: doctors are causing this addiction in patients they prescribe to. Next. So what about dentists, and how is our prescriber behavior directed? First of all, we're creatures of habit, so we have established prescriber behavior. We tend to use a controlled substance Schedule II, as such as Vicodin. The placebo effect of writing a prescription. We tend to treat for the most severe outcomes. And then the challenge of meeting expectations and demands by patients. Next. So one of the challenges is, one of the prescriber behavior barriers that we see is patient expectations. A survey done shows that patients expect to be prescribed opiates for their pain, and they object when alternatives are given to them. So that represents a significant challenge for us as prescribers. Next. So looking at prescriber profile by dentist, what you should notice the following: we are, as was noted before, was that we are one of the top prescribers of opiates. What's interesting is you compare a similar country in terms of demographics and education, and what we see is a significant variance in prescriber behavior. When we're compared to the United Kingdom, we prescribe at a rate 30 times higher than a dentist in the United Kingdom. That overprescribing by dentists essentially has remained unchanged to this date. Next. So it's already been noted that oral surgeons are one of the highest prescribers in the specialty, in the profession of dentistry. So here's the dichotomy. In a survey of oral surgeons, the overwhelming practitioner prefer ibuprofen, and yet we prescribe 85% prescribe an opiate combination for our patients. And it's already mentioned that the most common procedure that we prescribe opiates for are third surgery. And obviously the age group that we're dealing with is between the ages of 10 and 30. And the most common is combination of hydrocodone and Tylenol. Next. What this is a slide shows, which is what we talked about today about concern, is that it shows that dentists are the highest prescriber of opiates from the ages of 10 and 19. On the right-hand side, as you can see in that red note, is that dentists are also the highest prescribers to someone with a current prescription. In other words, we are the brunt of doctor shopping by patients who are looking for an opiate prescription. Next. So this is a study that really kind of dramatically shows that there has been essentially no change. In fact, an increased shift in dental prescribing habits to young people. As you can see in the bar graph, in the blue is 2010, and then the green is 2015. If you look at the bar graph in the ages of 11 to 18, we see that compared to all other age groups, this is where the most significant increase, about 11% that we've seen in terms of opiate prescribing to young people. So that increases should be of significant concern as we, in our profession, try to address our prescribing behavior. Next. So why should this be of concern to us? In a study reported in the Journal of Pediatrics in 2015, the title of this paper is Prescription Opiates in Adolescents and Future Opiate Misuse. So the conclusion was that legitimate opiate use before high school associated independently with a 33% increase in the risk of future misuse after high school. Now, in this study, you should note that these were students who were naive to opiates. In other words, they did not have previous exposure to opiates, did not have a substance abuse issue. Next. So any use of opiates for acute pain increases the probability of chronic opiate use. In fact, even a very short, if you will, 14 to 15 day prescription of opiates, basically you have a 20% chance of misuse of opiates after 1 year and 10% after 3 years. So the likelihood of misuse of opiates is significant even for a short, if you will, prescription of opiates. Next. So if you look at the most common substances that people abuse or become addicted to, you can see that in this study that addiction to opiate have a 40% chance more likelihood of being addicted to heroin compared to alcohol, marijuana, and cocaine by a significant number. Next. So there are some positive changes. We've seen actually the most recent study shows that we've seen about a 45% decrease from opioid prescriptions since the height of 2013. Next. We also have seen a dramatic decrease in opioid prescriptions. You kind of have to look at this number in the frame that in 1998, the US population was 200 million. And 2012, I think it was climbing to close to 300 million. I think we're right now at 333 million Americans. So, but we have seen a positive decrease change in the number of prescriptions written by dentists. Next. So how should we respond? So this was a thing that was in Times Square, which kind of showcased one of the things that it says, would you give your child heroin to remove a wisdom tooth? Next. So this is, again, I want to emphasize what the takeaway from my lecture should be before. Where dentists are overcompensating for the level of pain. Pain is being overrated by both dentists and patients. NSAIDs are sufficient analgesics, and pain should no longer be the image of dentistry. Next. So what we did at the School of Dentistry was really focus on dentist prescribing. You know, obviously, the time period that we have we don't have the time to talk about all the various modalities that are being used to address the opioid epidemic. But Dr. Rake and I, really our focus was on how do we address changing our colleagues' prescribing behavior, if you will. Next. So our focus was to establish a protocol for safe post-operative use of opiates when it's indicated, and was not to supplement and replace individual prescribers' clinical judgment. Next. So the bottom line is our guidelines was to use NSAIDs as the first line in terms of acute pain management. Next. So what we're really seeing is really the implementation of the protocol, which was in October of 2016. But what was really interesting was, so if you can see the height of, which is in the fourth quarter of 2015, where we're prescribing at 1,136 opiate prescriptions. Well, starting at that period of time, I and others began educating the students as well as the faculty about not only the epidemic, but also made them aware of the impact of pain management and use of NSAIDs. As you can see, that with that alone, that awareness and education, we are already beginning to see a dramatic decrease in prescriptions of opiates, because what we really started with implementation of the protocol in 10/1 of 2016. And with that implementation, we've seen it's just a dramatic decrease in the overall use of opiates at the School of Dentistry, dropping down to well over 80% now. Next. Not only did we see a significant decrease in the use in the opiate prescription itself, but also in a number of pills, going from a high of 16 to now down to 12 pills per prescription. Next. This is one really that dramatically shows what has occurred. As you can see, the two lines, the red represents opiate prescriptions and the green represents NSAIDs. So as our prescribing behavior changes, the number of opiate prescriptions just dropped. As it drops, the number of prescriptions for NSAIDs increase. So it crossed over in the third quarter of 2016. And that information is pretty credible because we write prescriptions for both opiates as well as for ibuprofen at the School of Dentistry for our patients. Next. So one of the questions is, well, maybe all you did was leave patients in pain when you didn't give them narcotics. What we looked at was 172 patients, which was in a period of time, 20% of those were prescribed opiates following the procedures. And what we noted in the 20% of patients, in the hundreds, and the patients that were given ibuprofen, acetaminophen, only 2 patients, if we will, fail that protocol and were given follow-up opiate prescriptions, just representing about 1% of those patients. So what we've seen is that in acute pain management using NSAIDs, that was highly effective, and pain management failures was very, very small. Next. So what we've seen is prescriber behavior, we can conclude that it can change and it should change in the School of Dentistry, and it did change at University of Minnesota School of Dentistry. Next. So this is the takeaway. And again, the level of pain has been overcompensated. It's been overrated by dentists and patients, and NSAIDs are sufficient analgesics, and pain should no longer be the image of dentistry. Next. So you should know that actually there is now a combination of both acetaminophen as well as ibuprofen, and is highly effective, especially in the use of for acute pain in dentistry. Next. Thank you. And I'll wait for questions at the end. Thank you very much.
Thank you, Dr. Tu. And so now we'll hand it over to Dr. Rake.
Yeah. Thank you. Can you hear me okay?
Yes, we can hear you.
We'll go to the next slide, please. So thank you for inviting me to speak on a topic I am very passionate about. I have been advocating for many years on responsible opioid prescribing. And for me, what started out as a personal and grassroots effort has taken me places I never would have imagined. Being here today with you all is one of these, and for this, I am very grateful. Next. So why is it so important we continue to talk about this topic? These are results from the 2019 Substance Abuse and Mental Health Services Administration survey. Next. And the results they found, this is for people aged 12 and older, 60% used an addictive substance within the past month, over 50% drank alcohol, and 13% used an illicit drug in the past month. The top 4 most abused substances in the United States are alcohol, tobacco, marijuana, and prescription pain medications. Next, please. So when we talk about postoperative pain management, I think it's really important for us to take a step back and really understand what exactly is pain. This is the definition and from the International Association for the Study of Pain. It has remained basically unchanged since it was originally defined in the 1960s. I think it is important for us to point out that not only is pain a sensory response, it is also an emotional experience. Next slide, please. This is a picture from a magazine I took about 5 years ago. Now, unfortunately, half of US adults have a close friend or family member who has been addicted to a prescription pain medication. Next slide. Unfortunately, I am one of these people. I describe myself as a sister grieving the loss of a brother that is still alive. My little brother, my best friend growing up, is gone. He is still here physically on earth, but the boy and the man I know is gone. In 1999, at the age of 26, my brother graduated magna cum laude from Pepperdine University School of Law. Not only did he obtain his law degree, he also obtained his MBA and landed his dream job. 4 months later, he was diagnosed with testicular cancer. He was prescribed Percocet for pain and became physically dependent on them while taking them as prescribed. My brother and I are very close, or were very close. We were first-generation Americans and the first in our family to dream of going to college and actually graduate. I vividly remember my brother calling me after his first surgery. I was in my residency training and on my general surgery rotation. I asked him how he was doing and about his pain. He said he was doing okay and his pain medications made him feel good and took away his pain. He asked me if he should keep taking them. And I said, of course, your doctor gave them to you for a reason. This is what I was being taught and advocated in my education at that time. And I was managing surgical patients like my brother. This conversation has haunted me for over 2 decades now. My brother survived his cancer, but never recovered from his addiction disorder. And his life is now that of a heroin addict, living homeless on the streets in Seattle, the last I heard. This is my brother. This is a mugshot from the last time I saw him. I cannot show a picture of him before his addiction. Not only is it too emotionally taxing on me to show a picture of him as I remember, but I show this to illustrate the transition from being an attorney who graduated from one of the most prestigious law schools in the country to having a mugshot taken. The devastation substance use disorder can cause is widespread, and there is zero discrimination. Very sadly, I realize my family's story is a typical one, and millions have felt a loss. It is imperative we start treating substance use disorder as the chronic remediating disease it is, and recognize this is an equal opportunity disease and killer. I share my story to illustrate removing the stigma from substance use disorders is imperative. Next slide. Dr. Tu showed this slide. I do want to point out it is not obvious to both patients and even some prescribers that hydrocodone, which is the opioid in Vicodin and Norco, and oxycodone, which is the opioid in Percocet, are semi-synthetic drugs derived from opium, the same as heroin. It is very true, and we should all be armed with the knowledge that our brain perceives these as no difference, and this is important for us all to know. We should be aware of this, but I do think it's important to take a step back and not let this swing the pendulum to the point where patients may not seek care or experience unnecessary suffering with severe pain. We should not think in terms of being anti or pro-opioid, but in terms of being pro-patient. Next slide, please. So looking more specifically at the third molar age demographic, this is a retrospective cohort study conducted and led by Dr. Scott Hadland, who is chief of the Division of Adolescent and Young Adult Medicine at Harvard Mass General. He is also an addiction medicine specialist. His study was aimed to identify patient and prescription characteristics associated with subsequent risk of opioid use disorder or overdose during the year after an initial opioid exposure. They looked at a database from 2006 to 2016. The age demographics was between 11 and 25 years of age, filling an initial opioid prescription. And they looked at over 3.2 million patients. They found 1 in 315 youth would develop an issue. This equates to 0.3%. So just keep that in mind for one moment. They did find 2 very screenable factors I think we should talk about. Number 1, if a patient had a mood or anxiety disorder, they were 4.5 times more likely to develop issues with addiction. And number 2, youth who use other substances were 20 times more likely to develop an issue with opioids. I bring this up because as a doctor, we would say this is a low risk. However, as a mother, 1 in 315 is unacceptable. And the number, and as a surgeon, these are very easy things for us to screen about and alter prescribing patterns. Next slide, please. So as Dr. Tu, next slide, please. As Dr. Tu showed, the efforts of Big Pharma infiltrated our education, influenced research, influenced lobbying efforts and healthcare facility protocols to increase sales. I think it's important to recognize there is a transformation from opioid use being reserved for very specific indications to use for chronic pain. And it was the perfect storm. If opioids were safe to use for chronic long-term use, surely they would be safe for short-term use in acute pain. And we now know that this is not the case. Next slide, please. So I admit, in the past, I prescribed as to what was an accumulation of my education, what I was taught in school and residency training. Opioid monotherapy worked and was the standard of care then, but it is no longer. Non-steroidal anti-inflammatories were not well established until the research Dr. Tu presented. We were ignorant and misled as to the powerful potential of opioids. I'm happy to report since 2015, I have aggressively altered my prescribing pattern and reduced the number of opioid prescriptions by over 90% with effective pain management. Next slide, please. So a white paper is a guide that informs about complex issue and represents the issuing body's philosophy on the matter. This is the American Association of Oral and Maxillofacial Surgeons white paper on opioid prescribing that was published in 2017, supporting providers use non-steroidal anti-inflammatories, so medications like ibuprofen and Motrin and acetaminophen or Tylenol as first-line analgesics. Next slide, please. So this is from the American Dental Association Practical Guide of Substance Use Disorder and Safe Prescribing. It supports the use of perioperative steroids. Steroids, unless contraindicated, have been shown to be safe and effective means to reduce perioperative pain and swelling. Next slide, please. So what are wisdom teeth and why does this procedure need to be done? This is some of the dialogue that I have upon consultation with patients and their parents. We typically obtain a panoramic radiograph, which is an X-ray that provides full view of the upper and lower jaws, the temporomandibular joints, and the sinuses. This image is produced by a machine rotating around the patient's head and taking the midsection through the jaws and laying them flat on our screens. I'm sorry I don't have a pointer, but the wisdom teeth are the last teeth in all four corners. All of these teeth are impacted. Impacted just means the tooth or teeth are not fully erupted inside of the mouth in the proper position. And this is very typical of wisdom teeth or third molars. We recommend impacted teeth, if the benefit outweighs the risk, be removed for many reasons. But the main reasons are from a medical standpoint, when teeth are underneath the gum tissue, either partially or fully, they sit in a lining of tissue, and that is the same tissue that helped initially make the tooth be formed. Sometimes later, the cells in that tissue can reactivate and start to grow again. They will not form another tooth, but they end up forming a cyst that can be very destructive to the jaw and the teeth around it. So for preventative reasons, we recommend that they be removed. Also, if you can imagine these teeth trying to push inside of the mouth, they will end up going into the back aspect of the teeth in front of them, causing damage and also potentially causing other teeth to shift or become crooked and crowded. When I have conversations with patients and parents, it is important that we educate on what to expect postoperatively. This helps alleviate what we learned about the emotional component of pain or anxiety that may be related to surgery. Education on what causes pain from this procedure is swelling, and that we are very aggressive about trying to minimize swelling. Typically before removal of the teeth, we do a burst of steroid injection. We also discuss following up with a course of that. And even though the steroid is not classified as a pain medication, because it treats what causes pain, it will act as a very potent pain medication. Also, arming the patient with the knowledge that the combination of acetaminophen and ibuprofen has been shown in multiple studies now to be as effective or superior to an opioid is beneficial. I do educate that all of these medications are additive in nature and that opioids are not indicated for this type of procedure. I also instruct them on other modalities to reduce swelling, such as elevation and ice. Postoperatively, what to expect is important for patients to know as well, arming them with the knowledge that 24 hours after the procedure and even up to 48 hours maybe when peak swelling occurs, which will be the height of their discomfort. Next slide, please. Involving the patient and their parents in the development of postoperative pain management plan increases their understanding and timeline for care. As I mentioned, I do practice full scope oral and maxillofacial surgery. Some of the surgeries and injuries I manage will at times require the utilization of an opioid. And I do, as a doctor, have to keep in mind that it is still the standard of care for severe pain. If an opioid is used, however, it is done differently and with the education and with some consent with the patient. Next slide, please. So since about 2016, prior to prescribing any opioid, I do educate the patient and utilize a consent or patient agreement. On this form, it clearly states the side effects. It does state the medication can be addictive. And I think very importantly in terms of potential diversion, it says how to store them and how to discard any unused medication. Next slide, please. So in conclusion, my advocacy and plea as a surgeon, sister, daughter, wife, mother, and fellow citizen is for all of us to educate ourselves, our patients, and the community about opioids and continue to change prescribing patterns.
Thank you, Dr. Rake. And now we'll hear from Dr. Kat Marriott.
All right. Thank you so much, Kathleen, and all of the other students at Georgetown for asking me to participate and allowing me to join in your advocacy efforts. I am the executive director of PROP, which is Healthcare Professionals for Responsible Opioid Prescribing. And we are an organization that was formed around 2010 by a group of physicians that were concerned about the trend of increased opioid prescriptions for new and different indications that were not indicated previously. This group of physicians authored a document known as the Myths and Facts of Opioid Prescribing, which was titled Cautious Evidence-Based Opioid Prescribing. And this document was supported by numerous organizations and is still cited today for the accuracy and the advocacy for cautious opioid prescribing practices. After that time, the physicians formed the nonprofit organization now known as PROP. And over the years, members have joined in advocacy efforts, including petitioning the FDA to change the upscheduling of hydrocodone and provided input to the development of the CDC guidelines, which were released in 2016, and have supported many other efforts, including label changes for opioids. Education remains part of the hallmark of what PROP is all about. And one of the major education efforts of PROP in 2013, PROP addressed the Federation of State Medical Boards in their flawed policy and guidance that was released in 2013. And PROP continues to address the FDA curriculum for opioid REMS and supporting legislation that promotes education around responsible opioid prescribing practices. So our primary activities are to advocate for better regulation of opioid manufacturers, distributors, and for more effective federal and state response to the opioid crisis, as well as advocating for public and commercial insurance coverage for evidence-based pain treatments. Education to promote evidence-based treatment of acute and chronic pain by physicians, dentists, nurses, and other health professionals, and to oppose drug company initiatives to expand opioid prescribing for common chronic pain conditions throughout the world. Over the course of the years, PROP has accomplished many things. PROP has changed the narrative and improved the media narrative regarding the safety and effectiveness of opioids for managing common chronic pain conditions. PROP highlighted the big pharma lies that led to the flood of prescription opioids. PROP helped tighten federal opioid regulations and guidelines, including opioid label changes, upscheduling of hydrocodone combination products such as Vicodin, Lortab, and Norco. And PROP was also part of the construction of guidelines for the CDC, the VA, and the AHRQ. PROP has raised public awareness of the pharmaceutical industry's role in the opioid crisis by exposing the opioid industry's false and deceptive marketing tactics. So our mission is to reduce opioid-related morbidity and mortality by promoting cautious and responsible prescribing. Our vision will be to maximize prevention of avoidable morbidity, mortality, and disability due to unwarranted prescribing of opioids for pain. PROP will achieve this vision by communicating scientific knowledge about opioids and by combating misrepresentations and harmful prescribing practices and policies with the goal of making pain management effective, safe, and evidence-based. So really our purpose is to promote the safe use of opioids for the treatment of pain in the United States, not to reduce all or to eliminate all prescription of opioids. This includes the use of opioids for the treatment of opioid dependence, or OUD, in patients using opioids for the treatment of pain. This also includes reducing co-prescribing that increases opioid risk. Expand the mission of the PROP beyond the United States to counter industry messaging outside of the United States, as the pharmaceutical industry is actively trying to promote opioids, more increased opioid use outside of the United States, and continue to be champions of good pain practice. So this series of graphs, as you can see, this map of the United States shows, starting in 2006, how opioid dispensing increased dramatically over the course of the years and has only recently improved, so that now across the United States in 2020, we are now finally below an average of greater than 100 opioids dispensed per 100 people. But there's still much to do, as locally and regionally, dispensing rates are still elevated over the rate of 100 opioids dispensed per 100 persons. So which means that regionally, every single person there's enough opioids dispensed for every single person to have an opioid pill. I won't go over all of these details, as Dr. Tu and Dr. Rake so eloquently described what has happened over the course of the years. But the dispensing rates continue to remain at high levels across the country. Currently, according to many sources, 1 in 25 adults utilizes opioids for chronic pain conditions. And the purpose or the focus of PROP is to look at prevention when it comes to opioid prescribing and reducing initial exposure to opioids in order to prevent addiction, dependence, addiction, and eventually, hopefully not overdose. My motivation and the purpose, or the reason why I work with PROP and serve as the executive director, very similar to Dr. Rake, is my sister Sarah. My sister was diagnosed with an autoimmune disease called dermatomyositis, and this is a painful autoimmune disease, and she was diagnosed with this in 2005. Similar to lupus, dermatomyositis is patients experience flare-ups, which are very painful. And in 2009, my sister was hospitalized for a serious flare-up. She was actually in a medically induced coma for several days. And following this hospitalization, she was prescribed opioids as long-term therapy for her pain. By 2013, she was fully dependent upon opioids, and she was buying prescription opioids on the black market. Her tolerance had reached a point where her medically prescribed opioids were no longer treating her pain, and she was abusing opioids. She began using heroin, and began selling her legitimate prescriptions to fuel her addictions. One thing that I want to mention in connection with the dentistry world is long-term heroin users often have serious dental issues, and my sister was no different. She experienced abscessed teeth and had serious dental issues once she started using heroin. And the dentistry was one of the prominent sources of prescription opioids that she was able to obtain on a somewhat regular basis to either sell or continue her addiction and to promote her addiction. And this is something that has been, looking back, was very problematic for our family. In 2016, my sister died of a heroin overdose. She was incarcerated. Similar to Dr. Rake's brother, my sister was incarcerated for larceny, and following her release from jail, she was relatively clean. Unfortunately, she was released during the time where it was the height of fentanyl being moved into the illicit heroin market, and whether or not it was accidental, she overdosed and died in 2016. And I miss her very much. These pictures show, unlike Dr. Rake, these pictures show the sister that I prefer to remember fondly, and the times that we shared together that were good and happy. The last few years of her life were riddled with incarceration and psychosis and homelessness, and it was devastating for our family. And it is because of my sister that I advocate and educate with PROP for reducing unnecessary exposure to opioids for as many people as possible. So this is the contact information for PROP if you would like to learn more about what PROP does, and to get in contact with us for any reason. And I appreciate the time and the platform in order to speak about opiates and the risks of opioid exposure.
Hello, everybody. My name is Kathleen Szymanski. I will be moderating the question and answer portion of the webinar. I first want to extend the most heartfelt thank you to Dr. Tu, Dr. Rake, and Dr. Kat Marriott. Not only do we want to thank you for the robust and informative presentations, but I think personally speaking, and I think on behalf of everyone in SOS Dentistry, and I would imagine in the presentation, we really appreciate your vulnerability and the humanization around the opioid epidemic. So I think that's incredibly meaningful. We will now move into the Q&A portion of this presentation. We've gotten a number of questions thus far. And then I want to remind you all that there's the Q&A box at the bottom of your screen. So please feel free at this time to submit questions that you might have for our panelists. So the first question that we did have come in is from a parent, and I will present this to the three panelists. What are some warning signs and symptoms of opioid misuse in my adolescent can I look for? So I will go ahead and present that, perhaps starting with Dr. Rake.
Sorry, I have to get unmuted. I'm sorry. So I think the question was around patterns of addictive behavior.
Yes, signs and symptoms that a parent might look for in their adolescent.
Sure. You know, I am not an addiction medicine specialist. So Dr. Tu and Kat, feel free to jump in. But, you know, most of the time it's just a change in irritability as the first signs if people, you know, are using and can't continue to find or use that drug of any substance. Yeah, I think I'm going to pass this off to probably Kat. She probably has the most knowledge on that.
Yeah, that's absolutely right, Dr. Rake. That certainly certainly changes in behavior is definitely, you know, one sign to look for, and the one of the things that that we noticed for my sister when I noticed that that there was abuse happening is that she was seeking doctors for situations where under normal circumstances that she wouldn't need to seek you know, multiple doctors, whereas she should have been staying with her one primary, her rheumatologist in the case of my sister. But, and that's, I mean, that's for prescription opioids. But for young adults, that, you know, there's a lot of information and there's a lot of data out there that is available. And I think that one of the things that we can do is provide some resources after the fact for parents. And there's a lot of organizations that address how, you know, how parents can deal with and talk to their children about opioids use and substance use in general. And as Dr. Rake, I am not a specialist in addiction medicine myself, but we will definitely, we can definitely provide our audience with some of those resources.
So let me add that, and thank you for that question, because I think it also touches upon an important thing that is oftentimes overlooked, is the issue of diversion. So almost all the studies show that 50% of prescriptions are not used. And so to that question is that, especially in young people, when they're misusing that medication, for example, they're given a prescription for pain medication, for pain, and they use it for pain. There's leftover medication, and they come back later and say, you know, I don't feel particularly well. I think I'm going to take that Vicodin because it really made me feel good. So misusing a prescription for what it was intended for is an early warning sign. Behavioral changes all the way ranging from, you know, when they were a good student, now they're getting poor grades or missing school, particularly if they're giving their medication to others or getting medication from others. So that goes both ways. I think the issue of diversion is something that parents should be very, very cognizant of. In other words, once those medications are used, don't have them hanging around, get rid of them. You can go back. There are a number of give back days to by pharmacies. You can take them back to pharmacies as well. There's some debate about flushing down the toilet, and I'm the one that I think that's fine. There's really very little evidence that this is an issue of contamination. There's some advocates for using, I think, coffee grinds and so forth. But I think the central message, I think that whoever asked that question is really important, is that that starts that journey. And I think early recognition of misuse and abuse of prescription opiates is really the beginning of that journey.
Thank you so much. I think those are really incredibly salient points. And that leads to another question that we have, I think nicely is, it might be two-part of a question. What questions should I ask? This is another parent asking, what questions should I ask my child's dentist if or when they prescribe opioids? And or what if the dentist might not agree on the parent's stance? So I would imagine our two dentists might have thoughts about this.
Sure. Yeah, I can speak on that. I did show the American Association of Oral and Maxillofacial Surgeons white paper on that. So that's the recommended treatment. And the ADA, I know your group is working with them. They do have a statement, policy statement, stating that non-steroidal anti-inflammatories and acetaminophen should be the first line drug. And I think it's important when we talk about dentistry, you know, people don't realize dentistry, DDS is Doctor of Dental Surgery. So we're either operating on teeth, or as an oral and maxillofacial surgeon, we're operating on teeth, jaw bones, and you know, the associated facial skeleton. So there's a big difference between like post-procedural pain and perhaps post-surgical pain. And, you know, I would be the first person, and I'm hoping I see it in my lifetime, that we have an alternative to an opioid for moderate to severe pain. But right now, that is all, you know, if we've maximized everything else, which should be step number one, the only other thing that we have to go to is an opioid for treatment. And personally, I think the patient needs to be involved in that decision. Am I gonna maybe power through a little bit of recovery, or am I knowing the potential risks going to take this medication? But we have to keep in mind that there is some patients that cannot tolerate acetaminophen or ibuprofen. With any drug, we're gonna have non-responders. And pain and the response to anything that we do in life as humans is a bell-shaped curve. So we're going to have people where that they just don't fall into what the studies show. So I think it's actively engaging the times of, I mean, I'm going to be very frank, and Dr. Tu can as well, you know, 5-10 years ago, everybody leaving our office was leaving with pretty much the same prescription. Everybody was getting, you know, everybody had their own little number, 10-12 Vicodin or 10-12 Percocet, and everybody got the same amount. Those days are gone. So it's tailored to the procedure, and you know, you should ask. You have the right to ask and be involved.
So I think first and foremost, the important message is that about choice. Parents have a choice, patients have a choice in who they go to, who get their care. And a consultation is a dialogue between the surgeon and the patient, and in this case, obviously, the parent as well. And in that dialogue, at least in my practice, I've moved away from talking about pain, but more about discomfort and functionality. And I think that that's really part of that dialogue that needs to take place. And as a parent, and to answer that question from the parent, I think it's important that with that dialogue, that discussion be taking place in terms of what to be expected: swelling, discomfort, how long, what are the things to be looking for. And within that framework, that discussion, especially in dealing with, if you will, a doctor who says, you know, I routinely prescribe opiates and you can take acetaminophen. And the parent says, well, I've become not only aware, but educated about this issue. And this is not only my concern, but this is a choice I would like to make. And so I think with that in mind, that's also about how and when you choose the doctor that you would go to. And I think surgeons, obviously, Dr. Rake has been, you know, if you will, highlights a surgeon who's moved away from it and effectively treat acute pain for her patients. So.
Thank you. And I really want to highlight what both of you had just said there, in that sense of, sounds like, and what I took from that is advocating for your child. So like you said, it's a dialogue. This isn't something that just because you get a prescription, that means we take it without question. It sounds like it's really that emphasis on a dialogue of knowing your child best and knowing the risks. So I appreciate that, Dr. Tu and Dr. Rake. We just got a really great question in the Q&A, and that states, since the argument can be made that the CDC recommendations on opioid prescribing led to peaks in opioid deaths, how do we deal with policy actions with good intentions that lead to negative outcomes going forward?
Wow.
So I'll take a stab at that. There is no doubt that policies are just that. They are meant to be, somewhat blanket statements that under certain circumstances can be misappropriated or misused. And the point where we come in terms of advocating and educating is that, as Dr. Tu and Dr. Rake said, pain and opioid use is a very personal situation that has to be taken, one-on-one. It can't be, these things can't be blanketly applied to, just every single population without taking into consideration. For instance, Dr. Rake said that, many patients do not respond well to NSAIDs or can't take them. It is unfortunate that there are negative consequences to some of the policies. And what prop also does is we keep track of the different legislative acts that are going on, both state and federal legislative acts. And some of these policies that are in the process of being either debated or turned into law are good intention, but are not evidence backed. So at the end of the day, any policy and any guideline going forward has to be based upon data and evidence, and that's the best that we can do. But we do know that unfortunately there are negative consequences to the blanket application of policy when it comes to prescribing, and when it comes to a lot of things. It's not a one size fits all for every single patient.
So I think one of the challenges in policy and where we are today is that people are looking for a simplistic relationship, a cause and effect. And let me give you an argument that's often made. Well, we've already pointed out in our discussion that the total number of prescriptions in the United States have significantly decreased. In fact, from 2012 down to 44%. And yet people argue, well, wait a minute. Number of prescriptions have decreased, and yet the number of deaths have increased. So it can't be related to prescription opiates. So the thing that people overlook is that the overwhelming majority of people who are dying from this epidemic are people who are substance abuse, right? They're previous heroin users and so forth and so on. The challenge for all of us is to see that this is a complex and global issue. Dr. Rake and I, we are not addiction specialists, we're not policy people, but what we're focusing on is how can we prevent that journey from occurring? And so we take in a piece of it. And I think for all of us, I think for the students who are involved in this, it's perfectly fine to acknowledge that, hey, listen, we're taking a piece of it and trying to move in that direction. It's about making a difference in the ways that you can be most impactful, rather than just sitting back and go, you know what, geez, it's just too large and too much. And so I think that's what I try to emphasize to my colleagues. We can do our part, and that part can make a difference.
Thank you for that piece. And that's incredibly relevant and something that our group has discussed as well, is that this is a topic that's deeply important to us and to many people. And where do we start and how can we do something about that? So another question that we just had come in from another parent that is really relevant here is, what can parents do to report inappropriate prescribing of opioids for their children?
I can take that one as the president of the Board of Dentistry.
Thanks, Dr. Rake.
So you definitely have the right to question, and if it is a dentist, you can send that on to your state board, and it will be investigated. And you don't need to know if it's right or wrong, but it will be evaluated by the board. I just wanted to take a step back and make one comment about the last question. Because I think there's a whole generation and a half of doctors that probably feel the same way as me with the CDC and this whole, big pharma. At this, I'm mad. I'm a little bit ticked off, and my education was very expensive and it was hijacked. Moving forward, when I really when I felt I was a friend with Prince, and when I lost my brother and Prince, it's like, well, what can I do? And I wanted to take, education. We need to re-educate ourselves and take ownership of using exactly what Kat said, evidence-based studies, and educate ourselves without any outside influence.
Thank you so much.
I also,
Go ahead, Kat.
I wanted to add to that, that I know that, so as Dr. Tu mentioned and Dr. Rake pointed out, the opioid prescriptions are decreasing, and we are getting back to the point where they were prior to the explosion of prescriptions in the late 90s and the early 2000s. Back to the levels where I believe it is more normalized. But what I want to point out is that the person that is exposed to opioids today doesn't enter, I want to say, the equation of the opioid epidemic necessarily today. It isn't until years down the road where their dependence and their addiction grows, where they become, I want to say, part of those statistics. So the more individuals that we can prevent from entering the cycle of addiction, eventually, and it won't be immediate, but there has to be an element of prevention as part of the picture of solving and addressing the opioid epidemic. It has to be, because otherwise, if we never address the prevention, and especially prevention of exposure to those young adults that are so vulnerable to addiction, then we're just feeding the cycle, and we're feeding more people into the addiction and the opioid epidemic picture.
Thank you, Dr. Marriott. So we are coming up on time. That absolutely flew by, and there's so much robust conversation that could be had here. There are a number of questions that we received in the chat and the Q&A that just due to time we were not able to get to today. But we invite you to please email us. We have an email at sosindentistry@gmail.com. So please email us. We would be happy to answer those and talk further to our panelists about responding to those as well. So just to wrap up our presentation here and our webinar with our panelists, we want to express our deepest gratitude to the three of you for being here, Dr. Kat Marriott, Dr. Tu, and Dr. Rake. And we also really want to thank each and every one of you that attended this webinar today for the fight to end the opioid epidemic and to really take care of those that we love and our loved ones, our community, and our children. So thank you for being here. We hope you have an absolutely wonderful weekend and a wonderful Thanksgiving holiday. And we are looking forward to being in touch with you all via our Twitter, SOS Dentistry, and our Gmail, sosindentistry@gmail.com. Thank you so much, everybody.
Stay well and get vaccinated.
Thank you for that, Dr. Tu. Yes, stay healthy. Thank you all.
Later, Jake.
Thank you.